morning, everyone. I'd like to thank everyone in attendance for your interest and support. I'd also like to thank Dr. Duke for mentoring me on this project and throughout my training. I'd like to thank SAGES for inviting us to present. This study was funded by a grant from the Lake Erie College of Osteopathic Medicine. No other disclosures, financial or otherwise, to report. I will briefly discuss the importance of VTE and prophylactic VTE in bariatric surgery, as well as the current recommendations. I'll go over the purpose of our study, the methods, results, and what we think lies ahead. Most bariatric patients are at least a moderate risk for VTE postoperatively. Despite this risk, the incidence of VTE still remains low. It has been reported 0.5% incidence of PE with fixed dosing and 0.6% incidence of symptomatic VTE with weight-based dosing. However, there is no consensus on the standard of care for prophylactic agent, duration, timing, and dose. The guidelines are as follows. SAGES endorses the American College of Chest Physicians guidelines. The American College of Chest Physicians recommends consulting a pharmacist to determine optimal dosing for obese patients undergoing bariatric surgery. The American Society of Metabolic and Bariatric Surgery recommend unfractionated heparin or low molecular weight heparin to be given within 24 hours. The 30-day and 60-day mortality was studied in bariatric surgery and found to be 0.3% in the top study and 0.25% in the bottom study. The top study showed that the third most common cause of death was PE, and in this Italian database on the bottom, the most common cause of death was PE. 30 milligrams of low molecular weight heparin twice daily was compared to a 40 milligram low molecular weight heparin twice daily dose, and DVT rates were 5 in the first group and 2 in the second group. Both groups had 1 patient each that was treated for hemorrhage, suggesting that 40 milligrams of low molecular weight heparin can decrease the rate of DVT without increasing bleeding. And lastly, through surveys, the French found significant discrepancies for thromboprophylactic practices in obese patients undergoing bariatric surgery. So we conducted a prospective study in patients undergoing bariatric surgery, 18 years or older, with no underlying coagulopathy and no history of DVT, to try to determine optimal dosing. The protocol was to obtain a baseline coagulable state and at pre-op testing using thromboelastometry or TEM. Patients were to get a 40 milligram low molecular weight dose 2 hours post-op. A second dose was to be given at 4 a.m. on post-op day 1, and a post-op TEM was to be performed 2 hours after that dose. All TEM analyses were interpreted by an experienced surgeon, blinded to patient identity, timing, and characteristics. Patient demographics and characteristics were gathered, including age, gender, BMI, lean body mass, Caprini score. 44 patients meeting inclusion criteria were consented and enrolled. 40 patients completed the study. The average patient was 44 years of age. The mean BMI was 43.6. Mean lean body mass was 139, and the mean Caprini score was 4. On average, the surgery lasted 200 minutes. Most patients underwent laparoscopic Roux-en-Y gastric bypass. The mean timing to dosing was 4 hours post-op for the first Lovenox dose, or enoxaparin dose, and 12 hours later for the second dose. And on average, the post-op TEM was performed 2 hours after that. On simple aggregation, TEM analysis showed that at baseline, 2 or 5% of patients were hypocoagulable, 37% of the patients were normal, and 58% of the patients were hypercoagulable. On post-op TEM, the results showed that 42% of the patients were normal and 58% of the patients were hypercoagulable. Of note, these 23 on the post-op we feel were inadequately anticoagulated. These 17 we feel were adequately anticoagulated. And on post-op, no patient was hypocoagulable. These findings alone suggest that 40 milligrams of low molecular weight heparin given twice daily is not enough to bring or maintain a normal state postoperatively. However, we didn't anticipate to find such similarities between these numbers here at baseline 15 and 17 post-op and 23 and 23, which prompted further investigation. So we categorized based on post-op TEM, and the TEM analysis showed through detailed paired analysis that 78% here of the patients that were hyper post-op were hyper at baseline, and 71% of the patients that were normal post-op were normal at baseline. So our suspicion that the baseline status is playing a major role is holding true. So we analyzed these two categories further. These groups were homogeneous on the following variables: age, gender, BMI, lean body mass, Caprini score, duration of surgery, type of surgery, and time to the second dose and to the post-op TEM. They weren't similar on timing to the first dose, uncovering the importance of timing of dosing. So on post-hoc analysis, again, we grouped the studies, or we grouped our patients into the two categories of post-op TEM, normal and hyper, and we found an association using Summers decorrelation between being normal at baseline and being normal hyper, being normal at baseline and being normal post-op, being hyper at baseline and being hyper at post-op. And this is seen with the 23 and the 78% and the 15 and the 80% here with the p-value 0.006. So our results imply that obese patients are inherently hypercoagulable. 2 doses of low molecular weight enoxaparin subcutaneously did not bring any of our patients into a hypocoagulable state. 58% of the patients were clearly inadequately anticoagulated. 42% we feel were adequately anticoagulated. Both of these numbers we think are related to their coagulation, baseline coagulation state, suggesting that obese patients require goal-directed therapy rather than weight-based or fixed dosing. Thank you. Any questions?